Good afternoon and good evening. Thank you so much for joining us for another edition of the Africa CDC Weekly Briefing. My name is Margaret Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Professor Yapum, the Deputy Incident Manager from the Incident Management Support Team based out of DRC. We also have technical colleagues on this call, and French translation is available on Channel 2. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you so much, Margaret. Good morning, good afternoon, good evening, once again, depending on where you are. It's really our pleasure to have you all connected for our weekly press briefing that I will be doing today on behalf of our Director General, His Excellency, Dr. Jean Casseya. So it's always an opportunity for us to see the number, but also the diversities of the journalists and the people who are attending this press briefing. And this goes beyond the public health emergency, as we've been seeing to the different questions that you'll be asking. That's also one of the reasons why we make sure that we have the relevant colleagues in case we need more clarification, explanation on the question that you have. So I'm pleased today to go through the presentation and, as mentioned, the different questions that you might have to clarify to get the right information of what is happening in the continent as health is concerned. Over to you, Director Margaret. Thank you. So we are having this vision that you are all familiar with now, the vision of Africa health security and sovereignty. This is our agenda. And by ours, we mean the agenda that is coming from the engagement, the conversation that we have our head of state and government to lead us to the transition from the new public health order to this new AHSS vision. Next slide. As you've seen in the first slide, we are in this new era following last week, the lift of the Mpox as a public health emergency of continental security. And then I will come back later to the transition plan on how we are going to integrate Mpox within the routine in the different member states that have been affected, but also to protect others. And as we want to protect the continent, it was important for our Director General to engage with the President of Angola, João Lourenço, who was also the chairperson of the African Union. So it was an opportunity to focus the discussion on Africa CDC's role in advancing the Africa health security and sovereignty, but also to advocate. This is the President and the chair of the Africa CDC Head of State Committee. So it's important to listen and then to hear from him the reaffirmation that Africa CDC mandate to strengthen the preparedness and the response across the continent. Next slide. We've also been engaged through our Director General to the engagement with the US Deputy Secretary Lando, and it was an opportunity to reaffirm our shared commitment to strengthen the collaboration between the US and Africa CDC to advance the public health security, pandemic preparedness, and resilient health system across the continent and the globe, because we all appreciate that what's happened in the continent is also supporting, contributing to the US security and safety, but not only to the global health security and sovereignty. Next slide. Now, we've also welcomed this week this tribune that was in Jeune Afrique, which was issued by our chair of the AAU, the President João Lourenço, in French, soigner l'Afrique, c'est soigner le monde. To take care of Africa is also to take care of the world. So it was really emphasizing the African health security, which is the global health security. And by that, he means that there is a need to invest in a resilient Africa health system that protects not only the continent, but the world, because we all know that epidemics know no borders, but also the sovereignty through sustainable financing, The reliance on unpredictable external funding, we've seen it, how the ODA has been reducing and how it has been impacting the continent. So now it has been the time to push with Africa CDC and the AU for durable domestic investment and regional solidarity, which are quite critical and therefore essential. And in that tribune, he also highlighted the Angola example as a proof that it can work. Angola has invested heavily in laboratory, genomic surveillance, emergency operation, workforce, data-driven decision-making, which has enabled faster crisis response, as we'll see later on the response to cholera when we'll come to it. But also, Angola has been very exemplary. As we are moving to the reform of health financing, you remember that Africa CDC will have the finance specialist in 16 to 20 countries in the continent that they will be supporting, and also the establishment of the African Epidemics Fund, the AFEF. It's a trademark, and Angola has contributed $5 million to that AFEF to ensure that we can reduce the financial mobilization between the time we have the outbreak declaration and the time we respond. So instead of waiting months to gather, to mobilize resources, the fund is there so that in the next 48 to 78 hours, we have the people in the ground, they have the funding, they have the material, they have all what is needed to control the outbreak at the source. But also in that tribune, he called for co-governance in 2026, meaning that Africa is ready to lead and indeed is leading, and therefore inviting countries and partners to join in fully operationalizing Africa CDC and AFEF, the African Health Sovereignty, which is a prerequisite for global collective security. So we really welcome this tribune and we invite all of you to read it. Next slide. During this week has also been the opportunity for our Director General to attend the NEPAD African Medicine Agency, AMA, program handover. So it was a critical milestone. Indeed, the transfer of the African Medicine Regulatory Harmonization and the AU Smart Safety Surveillance from the outer NEPAD to the AMA, which is really going to consolidate the Africa Continental Regulatory Mandate. But also it's a testimony of the strong continental foundation of the two organizations, which will lead to ensuring continuity and effectiveness, because this accelerate and structure handover was designed to be seamless and non-disruptive so that AMA can fully execute the statutory regulatory responsibilities across the continent. And therefore, our Director General, who was the guest of honor, has also emphasized the institutional continuity, stressing that the IMRH and the AU3S was rooted in the solid foundation of the two institutions working together for a safe and sovereign continent. Next slide. On Monday, Ethiopia has shown an example in leadership in responding to public health emergency. Indeed, the declaration of the end of the Marburg virus disease was not simply the end of an outbreak. It was really the recognition and of a commitment. So looking at the key driver of successful MVD containment, the first one was leadership. The leadership of the Minister of Health, of the Prime Minister at the country level on ensuring that the resources, the coordination of actors, partners, but also the team in the field was adequate. Over 4,000 people were tested, 14 cases were laboratory confirmed with 9 reported deaths. So the surveillance was intensified because of the integration. So the country leveraged the routine vaccination exercise for over 20 million to ensure that this was also the opportunity for active surveillance, meaning that while doing the vaccination, they were also screening door to door for MVD, and therefore the ability to control. It has also been an opportunity for the country to expand the laboratory capacity and to reduce the diagnostic delay, but also to screening for more than 5 million people at the point of entry. As you all know, Ethiopia via Addis Ababa Airport is really hub for the continent. The risk communication and community engagement was also quite critical. As I mentioned, the integration taking advantage of the other exercise of immunization that was happening at the same time. So therefore, it's a recognition of by the country to the health workers, the surveillance and lab teams, the EMT, but also the community health workers. If you recall, in the 5 key drivers for successful response control of an outbreak at the source, the community-based surveillance is critical. And this has been a very good example. But also the regional and local administrator and all the administrative, but also public health institutes that were involved at different levels. And last but not the least, the different partners who has been working together with the Minister of Health of ensuring that this was really an example of leadership on how we respond to public health emergency. Next slide. As you were all listening last week, our Director General has lifted Mpox as a FEX, as a sign of unified action. And he specifically highlighted that this was not the end of Mpox in the continent. As we'll see later, we have some countries that have seen a surge of Mpox cases. But really, or rather, the opportunity to transition Mpox moving from the emergency to the routine. And therefore, the transition roadmap that has been prepared together with the IMST, the member states sitting together to agree on what will be the role of the different partners, what will be the role of the country to ensure that Mpox is now part of the surveillance and the response and the routine. And to move forward and to ensure that we gather all the good practice of this response. An Mpox after action review will take place at the end of February in Kinshasa to ensure that all the lessons are learned, and we build on that to have a continental platform where we can integrate the preparedness, the response with all those different actors that have successfully responded to this outbreak, because definitely the lift of the FEX is the success of that coordination of all those members working together, and also the member state, which has been very, very, very fantastic on adhering to the different plan that has been issued and implemented. Next slide. So now going to our public health event, we can see the trend as we are already in 2026. We can see that if we consider the moderate and high risk, we have 56, while at the same time last year, we were already at 100. So it's important to appreciate that decrease. And last week, DJ was highlighting some of the driver on the fact that there has been a significant improvement in the member state in terms of surveillance, but also in terms of the actually celerity on responding to those outbreaks. But also, as we'll see for some cholera, and as we were listening this morning to colleagues from Nigeria highlighting how they've managed significantly to improve the access to water, which means all those efforts that has been put in place over the year are paying, and we need to accelerate. And I like the comment that one of the colleagues was mentioning today, the controlling of cholera in their country, Nigeria specifically, is already part of the routine. Now the focus is on the elimination, and all the effort that are being put in such disease will definitely impact all the other disease. Next slide. Now we want to make a highlight on diphtheria. If you recall a bit 6 to 2 months ago, there was a high-level meeting organized by the regional director of WHO Afro on the issue of diphtheria that is present in quite a number of countries, emphasizing the need to strengthen the collaboration and the coordination to respond to that outbreak. So now what we are seeing in Mali currently, Mali, which is also facing other outbreaks, including Mpox, we can see that there has been an increase in the number of confirmed cases. Now they've reached the 66 confirmed cases, 35 confirmed deaths, which is a case fatality of 53%, which is pretty high. We have 20 affected districts out of 75. And when we look at the location, we have those districts that have responded. We have Ségou, we have Mopti, Timbuktu, which account for 82% of the reported case, which also means that in terms of response, the fact that the case are majority located within those three regions, it's an opportunity to really strengthen the response to diphtheria there. That's why the different partner has been supporting the surveillance, also case management, but still challenge that inaccessibility of some of the areas and some of the shortage, but also the population mobility, which is a critical challenge in terms of contact tracing. However, the partners are supporting Mali to ensure that they can respond to this outbreak in the country. But beyond that, we are also looking at how this kind of disease can be integrated in this coordination approach that we've been using for Mpox, for cholera, and why not for diphtheria. Next slide. Next slide. Okay. Now, going to Mpox in the continent. Once again, the effects has been lifted, but Mpox has not ended. As we can see, we still have some of those few countries. Now we have included Madagascar, we'll come to it, which together with Guinea, DRC, Liberia, Kenya, and Ghana account for 91% of the confirmed case. Next slide. So before Madagascar, but still in the same area, in the same region, we have a new Mpox outbreak in the Union of Comoros. So to date, they have 9 confirmed cases out of the 9 suspected cases with 0 confirmed death. The location are 7 in the Grande Comore, in Anjouan. So it's important to more than 2,000 people who are moving from Madagascar to those islands every week. So what is important to appreciate with Comoro is the high level of preparedness. As soon as there were cases in Madagascar, we were in touch with the Minister of Health, specifically the General Secretary, to ensure that they are prepared in terms of diagnostic. Technician has been sent there to train the colleagues and ensure that the diagnostic was available. So when they have the suspected case, they already have the capacity to make the detection and therefore the confirmation. So now they are moving forward on ensuring that they also take advantage of this outbreak to strengthen the health system. But what is happening in Comoros and Madagascar, as we see later, is a bit different from what we are seeing in the other countries. Because of the island component, we need to contextualize and adjust the response so that it's appropriate to this environment. Next slide. Next slide. Thank you. So in Madagascar, which is nearby, we see a surge in the number of cases. We were discussing this morning but today, as the 28th, they are having 202 confirmed cases as we do speak. The clade that is responsible is the clade 1B. And what you can see as well is that 20 out of 114 health district has been reported with a confirmed case. And then one of the main challenges is that the local transmission linked to sexual networks. So that's an important point, as we've been seeing in other countries, how to address that population without the stigmatization. So this is the exercise that they are currently ongoing with the support of the different partners who are in the field. What you will see also as one of the key challenges that was highlighted to this morning during the meeting is the challenge of the active community-based surveillance. You can see the test positivity rate, 76.5%. And this morning they were reporting that it has decreased a bit to 52%, highlighting that the majority of the people who are tested positive are the one coming late, meaning that the majority remains still in the community where this active surveillance has to happen. And then we agree that that's where the support need to go to ensure that the community-based surveillance, which we've appreciated when we were talking about Ethiopia for MVD, is also something that we need to strengthen as the MST and as the different partners. So there are some major funding gaps that have also highlighted, but with partner, we are having the visit of the Regional Emergency Director of WHO in Madagascar, and also ensuring that we move together in the spirit of the IMST to ensure that we can support in the vaccination, as we see later. Madagascar will also benefit with some 30,000 doses of vaccine that has been approved by the Technical Review Committee. There are some administrative engagement to happen, but also on the lab side where they will be receiving more than 5,000 tests to ensure that they have the proper detection, the proper surveillance, and therefore to add the vaccination as a great component of their response. Next slide. In Kenya, we continue gladly to see the decrease in the number of cases. Kenya also, as you remember, have received an extra 20,000 doses of vaccine, which they're also preparing to vaccinate and ensuring that those hotspots that we keep on seeing, Mombasa, Busia, Nairobi, that represent 67% of the total confirmed cases, are really surrounded. One, on the side of the surveillance, as you can see, the test positivity has increased, meaning that the community-based surveillance is working around 39%. And on top of that, adding the vaccination where it's needed, we believe that we'll see some improvement in the coming weeks. Next slide. In Liberia as well, we are seeing an increase in the number of cases, which we want to believe is also connected to the fact that the surveillance has been strengthening following the interaction review. So therefore, going in the field will increase the number of people that we'll see. Though we can see that as compared to last week, we have an increase on the test positivity rate, which means we need to keep on accelerating the operation, find them all. This is the integrated way of having the surveillance, the communication, but also the vaccine that are coming to ensure that we have that comprehensive way of responding. The challenge that we keep on seeing is the percentage of confirmed cases that are still at home, 57%. So the government is also trying to find ways of ensuring that they have adequate facilities to hospitalize, admit the positive case. So we are also working with them to see how those who are admitted can have a holistic management, which include the feeding, the clinical management, and ensuring that we also stop the spread of the disease while taking good care of the patient. Next slide. Now, going to the vaccination, you are quite familiar with that slide. So the addition to today is that Zambia has rolled out the mpox vaccination since the 31st December, and they are moving very forward this vaccination. But yesterday, our technical review committee, this is the board composed with global experts, to assign the allocation of vaccine to different countries. So they decide on allocation of Madagascar that was discussed yesterday, with the suggestion of the recommendation of allocating 30,000 doses to Madagascar so that they can have a targeted vaccination on the key population. And there are other countries that are also on the pipeline. We have Cameroon, we have Comoros, we have Uganda, and also, as mentioned, other countries, Liberia, for example, who are also in need for more vaccine. Next slide. Still, as vaccine is concerned, gladly so, we can see that the majority of the country have used more than 50% of the dose that they have received, actually 70%. One of the challenges with the orders is that most of the doses that are currently available don't have operational costs, which means that the country has to manage to find those funds within themselves, which also push the agenda, as we've mentioned, of domestic financing. Countries like Uganda have done it very well, and they are even asking more doses with the confidence that they can manage to find the resources at the country level to ensure that they can protect their population. Next slide. Now, moving to cholera, just 3 to 4 weeks since the year have started, and though we don't have all the data yet for all the countries, we can see already the trend for with 6,000 cases and 93 deaths, with a case fatality ratio of 1.5%, and 10 member states have actually reported. So what is happening soon as cholera is concerned is that Chad will host the after action review where they will look at the lesson learned, but more critically, you will take the time to support them with the GTFCC and all the other partners to work on the national plan moving toward the elimination, because controlling is one thing, but moving toward the elimination is actually the goal. And that has to happen by 2030, which is just in 4 years from now. Next slide. Now, when we look at the evolution in the different countries, we see that DRC and Mozambique are the country where we keep on seeing an increased number of cases, 46% in DRC and 14% is in Mozambique. So now, for the example of Mozambique, which will come later, it's important to highlight the approach that need to be taken at the regional level, because we talk about Mozambique, but also we have countries like Malawi, we have Zambia that has also been affected. So it's important to highlight that for those, we really need to have that cross-border, those regional coordination. In terms of country that has been declining, Burundi, Somalia, we can see some good decline, though some countries like Angola has declined, they are still part of the high burden countries together with DRC and Mozambique. Next slide. Specifically for DRC remain the major challenge as we do speak now, with 76,000 cases, more than 2,000 deaths, a case fatality ratio of 2.76%, while we are really pushing toward bringing it down to 1%. As you can see, we are still a bit far. 21 out of 26 provinces has been affected so far, and we can see that the challenges are actually numerous. You have the conflict that we see later in the Kivus. We also have the challenge of weak access to wash infrastructure, which on top of the climate change, the flooding and all those make the situation quite complicated in this country. Next slide. Now, when we look in DRC, we try to compare on one side. You can see on the yellow, you have the epidemic province. And on the right side, you have the endemic province where you have the Kivus, the Olomami, the Otakanga, and the Tanganyika. You can see that the endemic province are definitely the one where we have the majority of the death in DRC. And what is the message here? The message is that if we don't provide sustainable solution in those areas, then one, we keep on increasing the burden of cholera in the endemic province, and two, we start now increasing the number of affected provinces. So if we don't address, and in blue, you can see the different water, river, and so on that are also the one most likely spreading the disease. If nothing is done, we'll keep on spreading the cholera throughout the country. So it's really a call for action for ourselves to ensure that we prioritize, as the IMST is doing, DRC as the key country now to really face the issue of cholera, not simply in brackets to control, but really to provide sustainable solution, which is definitely sustainable access to clean water, despite the challenging and complex environment that we have there. So moving to Burundi, Burundi also in one way is affected by the situation that we are seeing in DRC. Next slide. So we have the migration from the population which are in the eastern part of DRC that have also moved to Burundi, and then we have those big settlement camps where also we have an opportunity to spread of that disease. However, the response, the multi-sectorial approach that the country has taken is actually paying. As you can see, the number of cases has been decreasing, which also the result of the fact that not only the medical solutions are brought on board, but really the building of water borehole, also the water tank, and all those solutions are bring on board. But more need to be done to ensure that the sustainable access to wash are in place. Next slide. I mentioned before the case of Mozambique, where we are seeing that new wave of case with a significant increase in the number of cases. And what has been mentioning during our meeting recently is it's very difficult to control cholera in one country when the neighboring countries are affected. So though we are specifically talking about Mozambique, last week we were talking about Malawi, but also Zambia. So the coordination of the vaccination, for example, is critical to ensure that when it's happening in one country, we also vaccinate on the border on the other side. If not, we'll solve the issue in one country, and 1 week, 2 weeks, 1 month after, it will come back. So this is really the approach that we are working together with the different partners. There is a new project that the World Bank will be supporting in the eastern and southern part of the continent. And this within the IMSC will be the opportunity to ensure that cross-border collaboration and coordination bring us to a sustainable way of controlling the outbreaks. Next slide. In Angola, gladly, we see the reduction of the case, but as you've seen, we've been having for this outbreak 2.5% of case fatality ratio, which is pretty high, far from the 1% that we are expecting, because we have that those 898 number of cases out of 36,000 cases. So still, roughly, as you can see, 44% of Angola's population lack access to safe drinking water, and only 55% have adequate sanitation. So lots of effort are put in place to ensure that the country planification for water access is also influenced by the spread of those outbreaks. Because if the access to water is prioritized in the region that we know that are endemic for cholera, then as we move forward, the access to water will be increased, as we've seen this morning with Nigeria. And in those places, the case of cholera will keep on reducing. On top of that, the OCV vaccination, moving from the reactive one when we have 1 dose, which is given to the population, and we know that 1 dose of OCV will last around 1 to 2 year maximum, having the preventive with 2 doses, which will bring a potential of 2 to 3 years, if not more, will give ample time to countries to invest on the wash, on the toilet, on the access to water, so that even if there are cases of cholera that remain, but because the access to water will have increased, we'll have lower and less number of people affected by cholera. Next slide. Now, in summary, we started the week with the official declaration of the end of outbreak of Marburg virus disease in Ethiopia as a good example of leadership and integration on how we can use the routine to respond to outbreaks. So the diphtheria, as we mentioned in Mali, but also happening in many other countries, require more coordination, more support. Mpox is concerned, we are happy that the effects has been lifted, but as you've seen today, we have countries like Madagascar, Comoros, but also Cameroon and others who have seen an increased number of cases. So we need to use all the lessons learned in other countries to ensure that we can control the outbreak at the source with the support that we are bringing together to those countries, which some of them will soon benefit from the vaccine that will be provided to them. On the side of cholera, DRC now reporting the highest number of weekly cases in the continent. So it's critical that it remain the priority as cholera is concerned, not simply or only to control, but really to provide sustainable solution for that. Mozambique and Burundi remain the major concern as the number of increase with risk of spread. And as mentioned in Mozambique, Malawi, and Zambia, once again, emphasize the need to strengthen the cross-border coordination and collaboration. So with that, I'm now happy to take some of your questions, and then I have my colleagues who are also connected in case the question is addressed to them. Thank you. Over to you, Director Margaret.
Thank you, Prof. Let's cross over to the floor. We have Paul from the Lancet. Paul, you have the floor.
Yes, thank you very much for taking my question. The first question has to do with an update on the issue. Is an update on the issue we talked about extensively here last week around the ethics of the study in Guinea-Bissau, and whether that has also prompted the prioritization of supporting African countries around the issues of ethics of clinical research. Then I also want to, recently the Africa CDC launched, I saw the document around a central CDR, Central Data Repository. I want to know how that is going to work in practicality, considering the different dashboards and tracking systems for data that various African countries and their partners are currently using, and if this is not just meant to repeat what we've already had in several times. And if I can slip in one last one, is there an update on the Saving Lives and Livelihood Initiative? It's been a long while that we had an update from Africa CDC regarding this very expensive initiative. Thank you.
Thank you. Back to you, Prof.
Yes, thank you, Paul. And as you know, we are always happy to give you the opportunity to ask the different question. So since last week, there have not been any real updates from the engagement that we have with Guinea-Bissau. But actually, your question about the prioritization and the supporting of country for ethics, I think Dr. Musoka, who is leading the Directorate for Research and Innovation, will be happy to provide some of the what Africa CDC is doing currently. And because he's also the one leading the SLL, I'm sure that he will be glad to give you some update. They met just at the end of 2025 to really actually see the impact of the SLL. He'll be happy to provide so. For the CDR, Dr. Mercy is connected, so she will be happy to also provide some of the update that you've been asking. Over to you, Dr. Musa.
Thank you so much, Professor Yap. So, no, we've started since last year to build the capacity of ethics committee on the continent. We launched the program last year to start providing training in data safety and monitoring, both in collaboration with CEPI. We had 66 candidates that we trained last year from around 25 countries, and this year we started the same. But the more we do, we see the demands are high. For example, this year we want to target 40 DSP training for 40 candidates. We already have gotten 2,500 applicants. So it really tells you that there's a big need for building capacity, and we begin to discuss how we can expand that. Also in March, we already had a plan to launch a continental course on research ethics. This was started since last year. As a matter of fact, as part of our SLL-SA strategy to build online capacity for the continent. So all of these initiatives have been built because we've been working with ethics community across the continent to really strengthen their capacity. So there are no linkage. These are all programs that we started long before this Guinea-Bissau, and we continue to do that and expand the capacity of ethics committee. Only the bid of SLL officially came to an end in December. We've been doing some of the analysis. We're able to impact 51 countries across many services and intervention, from coaching to genomic sequencing capacity in about 40 countries. Thousands of people were hired, and of course, the initial initiative was for the COVID vaccines. We're able to deliver 37 million doses. There are plans for us to come up with official report. Now we are in a close-up phase, but we can say for sure that as a result of that intervention, we're able to touch 51 African countries across different interventions. Thank you very much.
Thank you so much, Papa. And also, just to add, to complement, the Africa CDC will also give opportunity to countries, ethical committees, when they have kind of complex study, they can come, as Guinea-Bissau is doing, to also get some expertise, which is part of the pool of experts that Dr. Musoka was talking about. Dr. Mercy, around the CDR.
Thank you so much, Paul. And I think this is a very important one. So the CDR initiative is by no way coming to replace existing systems or mechanism for data acquisition or data archiving and use. But it's the aim of this initiative is to enhance operational efficiency and supporting member states in data analytics, actually in alignment with Africa CDC's mandate. So basically, we have some key areas that are really very critical. One is enhancing the digitalization at continental level, and of course, it's also definitely streamed down to the countries. The second one is also supporting automation of analytics, as well as supporting data archiving, warehousing, as well as use. But for all this to happen, we know that we definitely need a system integration, which you've rightly mentioned. So as of now, we know that we have so many different systems that have been tailored towards improving on digitization as well as analytics and all that. But how do we ensure that we have some sort of integration across board? How do we ensure that we're speaking the same language across board? And that is where the Center Data Repository comes in. It looks into the standardization and harmonization of data across the different pillars of public health, as well as also ensuring that the health information standard guidelines and standards are well adhered to, not only at the continental level, but of course where the data is coming from, which looks at the member states. So it's definitely not going to duplicating, but ensuring that we have a structure at the continental level where countries can be confident to be able to share their data at continental level and also benefit from the automated analytics that it's going to generate. So with that, I'm hoping that maybe with the framework, you'll be able to read more and get more insights on what we're doing. Over.
Yes, thank you, Mercy. And all these rely on trust, and the trust that will lead all the countries to sign the data sharing agreement within them in Africa CDC and ensure that we can protect the continent data.
Thank you. Let's take the next two questions. We have one here that says, how does Africa contribute to global science and research positions? Let me go again. So how does Africa's contribution to global science and research position Sierra Leone and other member states to improve genomic surveillance within the continent? And then the next question is on the recent outbreak in India, the Nipah risk level for African nations, and what are the precautions being undertaken by Africa CDC to avert the outbreak from getting into Africa, given the free movement to and from India? Back to you, Prof.
Thank you. So once again, for Nipah, I will go back to Mercy, who is leading the surveillance within the IMST, and also for the research, of course, Dr. Fala will be happy to provide us some updates. Dr. Fala?
Thank you, Professor Yap. So if we speak specifically to Sierra Leone, we've already been engaged with Sierra Leone over multiple times with multiple research. As a matter of fact, Sierra Leone will be one of 3 countries that will be bringing to UVRI in Uganda to have the first training in plaque reduction assay for Mpox. We are bringing Sierra Leone scientists to Uganda because they have a BSL-3 lab to build the overall capacity. And we're going to be working with Sierra Leone to look at the dose reduction of Mpox. It's known in other countries in Europe, the US, but it hasn't been done in Africa. All of this is done in a bid to build the capacity of Sierra Leone to contribute. We've developed a protocol together with Uganda and DRC, and some of the contribution from that study is going to have big implications for our response to Mpox, because we'll be able to save 80% of the doses, and we're going to be able to measure that if we do reduce dose, if we can still have the similar immunogenicity and safety profile. So indeed, Sierra Leone, like many other African countries that we are involved with at different levels to support R&D to contribute to the body of knowledge. That's been one of our major missions as Africa CDC, to identify the African scientists, work with them to lead R&D across the continent. Thank you very much.
Thank you, Papa. And also, if you go on PubMed, you will see that Sierra Leone is one of the countries that have also been able to share the experience of the Mpox response, because beyond research, we need to have our voice being heard, because the question that you are asking is also, where do we see our African publication counting and shaping the global health? Dr. Mercy on the Nipah?
Thank you so much. And well said, we as Africa CDC are keeping a very close eye on this outbreak. So basically, the Nipah virus is a zoonotic pathogen. And so far, on the continent, we've not reported any human case. That's just so that we are on the same page. However, on the continent, we have some of the antibodies have been detected in bats, which of course, some of the carriers are natural host of the virus. So regarding the risk level of the disease on the continent, for now, we'd grade it as low. While we have the reservoir on the continent, and we also have a very strong Indian community in some parts of the country, especially in East Africa, like Kenya, Tanzania, Uganda, and also in Nigeria, we have very huge Indian community. But with the rigor in terms of the surveillance that we do have on the continent, and with the expertise in managing viral outbreaks on the continent, we therefore know that if there is any importation or any inoculation on the continent, we'll be able to pick that in real time. So as of now, the risk level for the continent remains low, and we continue to follow up on the evolution of the outbreak. Over.
Yes, thank you, Mercy. So important to highlight, to re-echo what was mentioned, but also to ensure that there is no stigmatization for the Indian community in those countries. The risk is low, the country are monitoring, and then we remain in alert. Over to you, Margaret.
Let's take the next question from the floor. We have Michael Guarisa from Health Times. Over to you, Michael.
Oh, okay. Thank you, Director. So to Professor Yap, now that the United States has officially withdrawn from the World Health Organization, I just want to find out what does that mean for public health interventions in Africa, and how does Africa CDC intend to support WHO's work to ensure the region does not lose out on the gains achieved so far? Thank you, and over.
Thank you, Michael. Let's take the next one before Prof comes in. The next question here is Africa's CDC taking up any new projects in sexual reproductive health this year? And what are those projects, and which member states are being targeted? That's a question going to Dr. Landry. Over to you, Prof, for the first question.
Yes, thank you. Thank you. As mentioned, Dr. Landry is the head of our primary healthcare. So now we know of course, the best people to answer the question on how the retrieve of US in WHO is really WHO. And then they also provide a communique early this week, which I really engage you to read. But beyond that, we've learned from the decreasing of the ODA that we need to do more with less. And doing more with less is what we've been doing within the MST, where we have that coordination of different partners so that we have one team, one plan, one budget. The advantage of that is that we avoid overlapping, we avoid duplication, and then we move toward prioritization. So the work that we'll keep on doing with the different partner, and more importantly with the member state, so that knowing and appreciating that the resources are limited, we are more efficient on the way we prioritize, and also on the way we use resources when they reach the countries. Over to you, Dr. Landry.
Yeah, thank you so much.
Dr. Landry, we can't hear you. I think you're on mute.
How about now?
Yeah, we can hear you.
Okay, thank you. No, thank you so much for the question. And it's an important topic that unfortunately is not always at the forefront when you're talking about health emergency. Maternal mortality on the continent remains one of the highest, and Africa CDC has prioritized addressing maternal mortality as part of our broader primary health care program. What is important to share with you today is that Africa CDC is launching as part of the Africa Health Security and Sovereignty Agenda, a continental initiative that will address sovereign data for health. It's an initiative that will leverage the digital transformation that is one of the pillars of the Africa Health Security and Sovereignty. We digitalize primary health care and ensure that all the pregnancy across the continent can be captured through our community health workers who will be equipped with digital tools and connected with the primary health care facilities, ensuring that all pregnancy are referred on time to the health facility to be able to meet the requirement of all minimum 4 antenatal care during the pregnancy, and those at risk will also be detected on time. That digitalization will also allow us to provide with policy makers with early and quality real-time data for decision making around the whole process of the health system strengthening, ensuring that we have information around supply availability, ensuring that we can channel the supply from one district to another, and making sure that when it comes to financing, we also have resources allocated for a maternal and child health program across the continent. So overall, Africa CDC is definitely embracing and more aggressively the agenda of maternal mortality reduction. And this initiative will be launched pretty soon through our Director General. Thank you.
Thank you, Dr. Landry. Let's cross back to the floor. We have Helen from START. Helen, you have the floor.
Thank you very much for doing this and for taking my question. I was hoping to circle back to the question that was asked by the gentleman from the Lancet at the beginning. He asked about the discussions about the ethics of the trial in Guinea-Bissau, looking at the Hep B birth dose. And Dr. Boom said that there's nothing new on the ethics front. I'm wondering if there's anything new at all in regards to the planning for that trial. Is Africa CDC involved in the discussions? Are you hearing anything about whether the trial will proceed, if they're making progress in revising the protocol? Thank you.
Thank you. Let's take the next one before Prof comes in. We have one here from Lamin from Gambia. The question is, what plans does Africa CDC have when it comes to health monitoring around port areas, since there continues to be movement of goods and services from various zones, which could be a risk for cross-border disease transmission? Back to you, Prof. I think the second question is suitable for Dr. Kieng Masi. Back to you, Prof.
Yes, thank you. Indeed, Messi will take the second one. So on the first one, as we mentioned, there have not been any development since last week. So all was mentioned either by the Minister of Health himself or by our Director General. But as we do now, we are waiting for the ongoing review that is happening. And next week, if there is any development, we'll definitely be happy to share that with you on one way or the other. Over to you, Mercy.
Sorry, I had a technical glitch. I didn't get quite well.
Yeah, so the question is around cross-border disease transmission, especially around the port area, and then how how the control of movement and goods and services is being done within those zones. Back to you.
So thank you so much. I don't know if this is referring to a particular pathogen because they'll require different structures in place. But if not, if it's a general question, then I'm happy to take it the way it is. So basically at Africa CDC, we have several initiatives aimed at really improving regional coordination and collaboration, which of course the cross-border bit falls within. One of them is building regional networks where countries are able to share information, they are able to coordinate and mount joint response initiatives at border points. And we can see this even with the cholera and of course mpox, where countries come together and are able to put up a joint coordination for response. And as Africa CDC, our role is to facilitate this kind of collaboration. We as a continental technical body, we also put strategic guidelines as well as protocols that really facilitate this collaboration. So we really do not recommend any restrictions in terms of population movement, because definitely you can't do that. We saw that with COVID, and we also really do not recommend any restrictions in terms of trade. So what we're doing is supporting the coordination across member states and also building regional networks in collaboration with our regional economic communities for countries to be able to share information in real time, as well as collaborate in establishing those joint response structures at border points. Over.
Yes, just to add that this is done within a One Health approach, because as the question was also oriented to the food, but also to the environment. Over to you, Margaret.
Thank you, Prof. Thank you, Dr. Massey. We have two more questions here. One is on, does Africa CDC have a plan for patients with hepatitis who are using antivirals regarding access and affordability to medications for high-risk groups? That's the first question. And then the second question is about how does Africa CDC improve the collection and management of health data in general in regards to health emergencies? So I'll pass over the floor back to you, Prof.
Thank you. So the first question, I will leave Dr. Landry answer it on the side of hepatitis, and then Dr. Massey will also emphasize all of the work that is being done with the data, but also the investment on the DHS2 of the tracker that we are taking as one of the legacy of the mpox. Over to you, Dr. Landry.
Yes, thank you so much for the question. And I want to take this opportunity to maybe recall the Cairo Declaration on the elimination of viral hepatitis, which articulates 6 pillars. And those 6 pillars are clearly aligned with what Africa CDC has articulated also in 2022 in our strategy for control and elimination of viral hepatitis in Africa. So elimination of viral hepatitis includes, first of all, a commitment to eliminate viral hepatitis as a public health threat by 2030. That's a commitment that our head of state have embraced around the Cairo Declaration. So it means that member states on the continent are aiming to have 90% reduction in new infection, 65% reduction in mortality due to hepatitis. It will require to scale up hepatitis vaccination, including universal and timely birth dose vaccination against hepatitis. It will require strengthening routine infant immunization. It will require prevention of mother-to-child transmission of hepatitis B. So that means we need to have screening during antenatal care and dose vaccination. I think this is also an important question, because when there is screening, there need to be access to treatment, antiviral and immunoglobulin. This is an area where we, Africa CDC, working with our member state with the capacity to produce locally those antiviral and immunoglobulin, would increase access on the continent for those antiviral. I think there's currently a program to increase access to those medicine between a country like Egypt. Egypt is one of the countries on the continent with a clear certification of having eliminated hepatitis C and hepatitis B. And Africa CDC is supporting access to treatment for other countries, an exchange between Egypt and other countries to increase access to treatment for those high-risk population. So that's one example I can share for this press briefing. Thank you.
Thank you, Landry. Dr. Massey?
Thank you so much. And I think that's a very important question. So basically, we're looking at it from 3 fronts. The first one is the guideline and protocol development that the Africa CDC does and really sets those standards on the continent for data collection and data reporting and all that. And we can't talk about this without also acknowledging the very great job done by the WHO on actually developing the IDSR, which has really set the pace and serves like a Bible for countries to collect data. And what we are doing is at Africa CDC, we have looked at some priority diseases, and there's currently a workshop going on for this year's disease prioritization exercise, where we are looking at most frequently reported diseases and those diseases that are of high impact. And we're trying to say, okay, maybe we cannot do it for all the 35 diseases, all the 36 diseases. Let's start with a few diseases that we know are frequently reported, come up with standard variables and indicators that countries are mandated to report on. I think this is one of the first areas that if we get it right, we can speak the same language. We are able to understand what the burden is, the distribution of the disease, and some of the underlying factors that also propagate the disease spread in countries. So that is what we've done in terms of the guideline protocols and all that. The second one is the capacity building, which is also very critical, where we also have some fellowships, like the Health Informatics Fellowship, bringing together experts across the continent or young or mid-career folks across the continent to also build their capacity on these areas. And the last one, which is also we had initially mentioned, is the infrastructure development. And this is where the DHIS2 tracker comes in. During emergencies, most systems that have been built on the continent does not support emergency data collection. And that's why you see most countries during COVID, most countries had to resort to using WhatsApp messages to send data to national levels, or they use Excel to collect data, and they could not longer use the systems in place. What we are trying to do is to improve already existing systems. And we know over 80% of the continent use the DHIS2. And we have been able to use the DHIS2 tracker to ensure that we have some level of integration across the different response pillars. This way, if there's a case, it has just a unique identifier, which of course would run through surveillance, lab, case management, vaccination, and all that. And that really improves on the data quality. The second one is also the central data repository, which of course at country level, we are really pushing for countries to have their their data centers as well, so that they are able to have a single source of truth where we have all this data being integrated, and they're able to actually generate information that would guide policy as well as action in real time. Over.
Thank you so much, Mercy. Over to you, Margaret.
Thank you very much. And with that, we have come to the end of the briefing this week. I'll pass over the floor to Prof. Yap for your closing remarks. Over to you.
Thank you. Thank you so much. Thank you, colleagues who have been joining. Thank you so much to all the journalists for the accountability that you are bringing to us to ensure that we keep on doing what we meant to do according to our new vision of Africa health, security, and sovereignty. And the diversity of the response also highlight that you give trust on Africa CDC to provide you adequate and up-to-date information. So I'm glad that my colleagues were all around, and feel free every week to come with different questions beyond the public health emergency, and then you will be able to receive the answer that we can provide to you. So I also take the opportunity to thank all our colleagues who are in the field fighting all those different outbreaks, epidemics, ensuring that we have a safer and sovereign continent. Thank you.
Recording stop.